Hi, hello all, and my apologies. I'm afraid a car crash on the motorway just blocked everywhere, and there was no way off it for me. So I'm very, very sorry, but glad at least I managed to get here even if late. And what I'm going to present to you is the evidence that's available in the use of HRT in women who have already had a gynecological cancer. And as you will see as we go through the presentation, there are elements and areas where the evidence is actually very, very sparse within the literature. I'm going to take each cancer as we go along and go through the pertinent information within the literature to see what we can do and indeed how we can advise our patients who have been managed. For ovarian cancer, as we know, there's a lot of these patients are in fact postmenopausal, and therefore the use of HRT is really not an issue in the vast majority of women who have advanced ovarian cancer and who also unfortunately have quite a poor survival pattern. So most of the work that we would talk about probably is more relevant to those under the age of 50 who get a variety of ovarian cancers. Nevertheless, there has been some randomized studies looking at the value of HRT in patients with ovarian cancer. One here by Lee, which shows a very small study looking at quality of life primarily, but also, of course, whether or not there is any impact on survival when such women are given HRT. As you can see, the randomization there was to HRT versus no HRT, and then two different types of treatment with respect to the estrogenic part of the combined HRT given to those patients. So the first thing we have to note is that the numbers are fairly small. They did target those in the premenopausal group, and as you can see, the average age in both of the groups here is approximately in their early 40s. Though of interest, there were quite a few patients involved in this study who had advanced stage disease or stage 3. I'd suspect that many of these ladies had stage 3 disease, whereby there wasn't large volume residual disease left behind, but it's not clear in the paper itself whether that was the case or not. Should also note as well that there are quite a proportion, maybe up to 50% nearly, of patients with mucinous carcinomas. This probably reflects the timing of the publication and the time span the work was undertaken. We now know that mucinous carcinomas are mainly those secondaries from a primary bowel mucinous carcinoma. And whilst it's number 2 here on the list of the types of tumors involved, in fact, they're deemed now to be a very rare ovarian tumor. And you have to take the results of this study in the context that a lot of cases probably put in here were in fact not ovarian cancer, but secondaries from a bowel cancer. The average follow-up was reasonable, as we can see. And when you look at the outcome with regards to survival, at least from this study, there was no evidence in these patients that using HRT or not using it impacted in any way on survival outcome. So that's somewhat reassuring that in those younger patients with those types of tumors, that you can actually use HRT where it's felt clinically indicated. Another randomized trial, and again, please note when the recruitment occurred, we are going back some years here, was done by Godozzi and colleagues, looking at patients less than 59 years of age. And arguably, you could say that that population between 50 and 59 may or may not be relevant in clinical practice. They did undertake calculations saying that to have an 80% power at 5% level, they would require 59 patients in each arm. The average follow-up, as you can see, was 130 patients. And again, it was a proper randomized control study in that one arm did not have any HRT administered. There was some loss to follow-up, which impacts ever so slightly, of course, on the target figures for the statistical analysis. The patients here, quite a few of the patients, of course, were in that over 50 age group. And again, I'd like to stress here that I am not sure in clinical practice how many of patients in the over 50 age group would actually wish to proceed or require HRT. Generally in the clinical setting, the focus is obviously on the treatment that they're receiving and their management. The issues in that population of postmenopausal symptoms are somewhat limited. It's not their major priority, quite understandably. Nevertheless, again, we can see here that we have a fair percentage of patients with advanced stage disease. Again, short or poor 5-year survival in that cohort. In stage 1 and 2, particularly in stage 1, many of these patients are actually cured from the disease, so it could be a long-term issue relating to those patients. But yet again, I need to stress, if we look at the very bottom, we can see we're dealing with a reasonable proportion of patients with mucinous carcinomas. Again, many of these are probably secondaries from a primary bowel carcinoma rather than being a primary ovarian cancer. And here we look at both the disease-free survival and overall survival in this study. And again, as with the first randomized trial I've shown you, no difference in outcome with respect to survival in those administered HRT versus those who did not have it. This just shows you the actual figures itself regarding both the disease-free and overall survival in these patients. And the stage itself didn't seem to impact either. So it's important, I suppose, to note the fact that if you are going to give HRT to such patients, at least you can say that with regards to early or later stage diseases, there doesn't seem to be an impact from what we can gather out of these randomized studies. This really here is a very busy slide, and I have no intention of going through it, but it's a meta-analysis or a systematic review of all the trials that are available, including case control studies. Again, not showing that there seems to be any major deficit to the patient or damage, if you like, to the patient with regards to outcome if you do give HRT. It's a reasonable paper to go through to try and, if you wish, to bring together all of the available literature that's published presently. And it just shows you again that we do not see an effect in relation both to the grade of the tumour or indeed the stage of the disease the patient presents with. There is an exception, of course, to this, and granulosa cell tumours, which can affect all age groups, but is noted, of course, in younger patients as well, is an estrogen-driven tumour. And there are if no reports at all that I could find on patients having HRT following a diagnosis of a granulosa cell tumour. Part of the reason for this is that in many cases, these tumours are at stage 1. So the woman, even younger, only loses one ovary and the other ovary is left in place. And secondly, of course, because they're estrogen-driven, we do recommend not giving HRT to any of these patients for fear of increasing relapse rates in these patients. So that probably is the major exception, I would state, of not giving HRT in ovarian cancers. The next major, or in fact it is the most prominent gynecological cancer now, having superseded ovarian cancer over the last decade as the primary cancer in the field of gynecology. This is due partly to improved survivals from breast cancer patients, aging population combined with obesity. Obesity is deemed probably one of the major reasons for endometrial cancer increasing. And just to give you an idea, in about a decade, the incidence of this disease has doubled. Of course, it's well recognized that endometrial cancer is influenced by the estrogen level that a woman has and is to a certain extent an estrogen-driven type tumor. Nevertheless, some studies have been done. The major study really is this one, done by the gynaecology group, which was a non-inferiority trial, randomized and double-blind, comparing estrogen therapy against placebo. And importantly, they did stratify the patients according to the substaging of stage 1 and stage 2 disease. We know that in stage 1A endometrial cancer, the recurrence rates are extremely rare, and therefore they were used as a cohort to compare with, but the randomization and the focus of recruitment was really on stage 1B/C and stage 2 patients. Advanced stage disease was not incorporated in this study. The therapy was planned for 36 months, and based on statistical calculations, it was deemed that there would be a requirement of over 2,000 patients randomized to these arms in order to have the power to see if there's any difference with regards to outcome. So this probably was the study that would give the definitive answer as to the impact of HRT following the treatment of this disease. And that would have been very interesting, as for many years, we all, from case control studies and cohort studies, had not actually seen anything published which suggested that HRT may be detrimental. It seemed to have been safe to use it. Unfortunately, or fortunately, depending on the way you look at it, the Women Health Initiative study reported in 2002, and the GOG study, the recruitment declined rapidly to the extent that they had to go back to the external panel who overviewed the trial, and it was deemed unrealistic to continue with this study, which is quite sad in the sense that the power was not going to be achieved. But nevertheless, that was the reality of life at that time. They did report, though, on the patients that they had recruited, and I think quite correctly reported on that, of just over 1,200 women with a median follow-up of approximately 3 years. As you can see again from this slide here, the distribution as expected was equivalent in both sides. There were a reasonable proportion of patients again who were in the older age population, possibly a population that again in a clinical setting, I'm not quite sure whether we would necessarily be giving estrogen therapy to women in their 70s and 80s. But nevertheless, this is the way the trial ran. And there were a very small proportion of patients who came in with more advanced disease than was the target population. Most of the patients, of course, had the stage 1B, 1C type disease, as is shown in this slide. What we can say, and we again have to take this with an understanding that the actual recruitment level was not achieved, but we can see that in both arms it seems survival is equivalent, endometrial cancer recurrence rates seemed equivalent, and the impact of patients having HRT didn't seem to impact on any of the cardiovascular elements in either arm. So they're both the very same. Death rate, again, unchanged in both arms. So what we can say from that study, albeit that it was incomplete and it had to be stopped early, is we can say that from that evidence that we have, combined with all the retrospective and non-randomized studies, that we don't have evidence that HRT seems to cause problems in women who've been treated at least with early stage endometrial cancer and then for whatever reasons required some adjuvant therapy, notably HRT. Notably, of course, that study was an estrogen-only study, not combined therapy. And in 2014, again, there's a very good meta-analysis done looking at all the information that's available. It incorporates just about 2,000 patients. And if we look at the graphs here, with respect to outcomes in all of those studies brought together, again, we do not seem to see any detrimental effect occurring with relationship to the use of HRT in patients previously treated or diagnosed with endometrial cancer. So a similar type situation to ovarian cancer, in that, yes, we have some randomized trials. They're not perfect, but when you combine everything that's available in the literature in both of those disease types, we do not seem to see that the use of HRT impacts on the outcome for these patients. This is again just showing you those studies in the meta-analysis. Again, most of them not showing any preference either way for HRT or not HRT. In the sub-analysis groups, there was a looking at combined versus estrogen alone therapy. They did not find any effect, but again, there is a word of caution because of the heterogeneity involved in these studies. As I state, these are not all randomized studies in the meta-analysis, and therefore they do warn about giving preference to either types of therapy, one over the other. There is one exception that has to be mentioned with regards to endometrial cancer, and that's the low-grade stromal sarcomas. These are quite a rare tumor in endometrial cancer, but from all the evidence that we have available, they do seem to have a strong estrogenic dependency. And in view of that, and indeed the difficulty in treating these tumors, it is the exception whereby HRT would not be administered to those patients. But I'd like to stress these are extremely rare tumors in the field of even endometrial cancer. And I'm sure there will be other situations at multidisciplinary team meetings where if the tumors, be they ovary or endometrial, have strong estrogen receptor positivity, that people will have some concern about the use of HRT. Regarding cervical cancer, this is the evidence we've got, and I've highlighted there yet again how far back we're going back 20 years to see about any study at all. In fact, this is the only one I could find relating to HRT after treatment for cervical cancer. When we're treating cervical cancer in younger patients, if it's a squamous cell carcinoma, we do tend to try and preserve the ovaries, quite often leave them in situ or move them out of the pelvis in case the patient needs adjuvant radiotherapy, which will give some protective effect to the ovaries. In the cases of adenocarcinoma, which constitute about 5% of all cervical cancers, they're the rarer subtype, there is always a concern regarding ovarian metastases in those conditions. Excuse me. For example, if we have squamous cell carcinomas, metastases may be found in about 1% of patients, which affect the ovaries, whereas in adenocarcinomas, it's about 5%. And over the years, there's always been concern of leaving the ovaries in women with adenocarcinomas. So the tendency is that they are actually taken out. From this small study, we can see some patients were not treated with HRT, which is your control group, and then we had two groups of patients, one getting estrogen only and other combined therapy. We can see there was no significant difference at all with respect to the 5-year survival in this study. And as I state, that is it with regards to cervical cancer. There are really very, very few, if any, other studies that I've come across trying to prospectively look at patients in a randomized fashion to see the impact of HRT in those treated with cervical cancer. Therefore, most of us would, if removing the ovaries in a young patient with an adenocarcinoma and that there was no metastatic disease, would have no hesitation in giving these patients HRT. Most of the patients, of course, with cervical cancer are of the younger premenopausal age group, and it's important that we try to maintain their normal hormonal profile as much as possible. For vulval and vaginal cancer, again, we're getting into even rarer conditions here, and there's no evidence at all with respect to patients having HRT after the treatment of either of these tumor types. Whilst vulval cancer can occur in younger women, there's a tendency that we can manage many of those just by dealing with the primary vulval cancer, not necessarily having to give adjuvant therapy in many cases, and they continue on with a normal life. Indeed, women have had children after the treatment for their vulval cancer. Vaginal cancer is even rarer again, and we very, very rarely encounter situations where the issue surrounding HRT use seems to arise. Equally, as I say, in vulval cancer, again, it's mainly a disease of postmenopausal women where the issue of hormone replacement therapy, again, does not arise. What we can say is that from some studies, and we can find studies equally that will reject this, but there is some concern out there about HRT and its potential risk of increasing HPV-related cancers. And this is to do with the fact of monitoring women on HRT and looking for HPV status through cervical smears to see what actually occurs. And whilst it may be a concern, I should emphasize that there are plenty of other papers stating that this does not seem to be the case. As I say here, that postmenopausal women continuing HRT long-term may lead to an increased development of HPV-related disease. So in that sense, it's only of a concern, but that does not necessarily mean it translates into an increase of vulval and vaginal cancers from what I've seen over the years in any of these populations. I just thought I would mention a couple of papers that you may find of value is the use of HRT therapy after prophylactic surgery. And what we can find is that there was no absolute, or there was some difference in the regarding of the incidence of breast cancer comparing estrogen alone to estrogen plus progestogen. We did not see anything in relationship to the use of HRT and the ovarian cancer element of things. But I just thought I'd bring to your attention that population, of course, potentially is an increasing population, particularly pertaining to ovarian cancer, whereby the removal of tubes and ovaries seems to be presently the only way that we can prevent this disease occurring. So I just wanted to get through some of the prophylactic elements. There are other studies relating to that, and it's an area so we need to keep an eye on as to what's the preferable approach to take. As we now know that many ovarian cancers actually arise from the fallopian tubes, there is a plan to start studies whereby, particularly in BRCA carriers, that we remove the tubes once the family is completed and then leave the ovaries in, and depending whether you're BRCA1, remove the ovaries at the age of 40 or thereabouts, and BRCA2, remove the ovaries before the age of 50. This at the moment is being discussed, if you like, around the world, but nobody's come up with an absolute study on this as yet. It does seem that there is interest from patients in this approach, which would avoid them having to be on HRT, because normally we would remove both the tubes and the ovaries, but we may see a change in practice with regards to that. So what we can kind of conclude with the evidence base that we do have available today with respect to the HRT use after gynecological cancer is that level 1 evidence is undoubtedly lacking. The GOG study was probably the only one that could have answered the question, but unfortunately I had to stop because of poor recruitment and the Women's Health Initiative study being reported. In some disease types in gynae cancers, such as low-grade endometrial sarcomas and granulosa cell tumors of the ovaries, we would avoid the use of HRT. Whether or not HRT impacts on HPV-related diseases is unknown, but from clinical practice and epidemiological issues, we don't seem to see any major increases in these diseases with time. And in fact, over the next 20 years, it'll probably become a moot point, as HPV vaccination will, of course, impact on the prevalence of HPV within the population. And quality of life for all of these women is important. And though it's rarely examined in the context of HRT in such populations, but I suspect for many of you who are menopausal experts, if I may put it that way, that is probably the primary issue that arises with many patients who have had a gynecological cancer treatment and are suffering from severe postmenopausal symptoms, is trying to get the balance correctly between the use of HRT to alleviate their symptoms and their concern about a potential risk that it might increase their cancer returning. And at least we can say to them, from what we know now, that depending on the occasional exceptions, we don't seem to see evidence that HRT has a detrimental effect with respect to recurrence of a woman's gynecological cancer. So thank you for your patience and your attention, and I'm happy to take any questions.
All right, thank you, Professor, for your presentation. Now it's time for the question and answer session. If there's any one of you who has questions, please feel free to type in your question, and I will help to read it for you. We still have a few minutes before the webinar ends.
Everybody's gone home.
Okay. No, actually, some people are still here. Okay, I think we got the first question from Kulafsana Khan. His question is, what about HRT in women with previous history of complex hyperplasia?
The issues surrounding complex hyperplasia, it depends on the type that they have. If it's complex hyperplasia with atypia, our standard approach on that, depending on the individual, would be to remove the uterus. If they completed their family, they don't want children, we would recommend removing the uterus, because there's about a 40% chance that they may have an endometrial cancer underlying that. In those cases, once the uterus is removed, I wouldn't have an issue about HRT. You could treat that as similar to an endometrial cancer stage 1. If the patient has a simple hyperplasia, then again, you wouldn't purposely want to put them onto HRT and potentially drive that into an atypical hyperplasia. You want to be very cautious about monitoring those patients on the off chance that they could develop an endometrial cancer and then say it's due to the HRT. The issue surrounding the simple hyperplasias, if I call them that, is that there's about a 1 to 2% chance some of those ladies, if they are left alone, will eventually end up developing a endometrial cancer. And your dilemma is really, you give them HRT because of symptoms, they develop the endometrial cancer, and your feeling is, oh dear, the patient feels that I shouldn't have had HRT. A way around that, and it is known that it's a good treatment, of course, is, and I appreciate it's combined, but you could always use a Mirena coil to control the local hyperplasia and then give some estrogen on the back of that. That's a way potentially around it. That's probably the best answer I can possibly give you, I think.
Okay, thank you for your answer. Next question is from Manjuna Vani. So a 50-year-old has VIN, has symptoms, and she has been or asked for VHN. Should she have HPV vaccine?
If she has VIN, then giving the HPV vaccine is probably futile. The reason for that is, if we have a 50-year-old, most of the, or not all of them in fairness, then we'll say 70%, maybe 80% of those ladies will have HPV present. The vaccine really needs to be given prior to you being exposed to HPV, as that's the way vaccines should work. It's to get the immune system geared up prior to being exposed to it. I do appreciate that there were some elements of studies and trials done by the companies involved in the vaccination program where they reported on a group of patients in the study and they did not know their HPV status and treated them anyway, and the claim being that it boosts the immune system a bit further and may help in reducing HPV-related precancerous lesions. It really is a difficult one that to justify, and essentially in that type of woman, I would not recommend HPV vaccination.
Okay, a continued question from Manju is, can she have HRT and how to counsel her?
With respect to patients who've got precancerous lesions, I would at this moment state that the symptoms and her quality of life, if poor, I would give her HRT. The supposition or the presumption that HRT may impact on your HPV status is debatable. As I said, I showed you a study where they said they have concern about it. There are equally studies saying we don't see any difference. So I think the practice would be that you deal with the woman's menopausal symptoms and treat her accordingly. And I wouldn't get concerned about the fact that she has VIN or has got HPV present. We treat, you have to remember, lots of women who are probably carrying HPV and we don't even know about it, and have done that over the years.
Okay, thank you so much. Next question is from Rika Wontakal. The question is, in patients with endometrial cancer, what is the time frame to when to start her immediately post-surgery, or do we need to wait for 2 years follow-up completion?
I think really if we've got early stage endometrial cancer, my tendency wouldn't be get too concerned about waiting too long because the outcome is so good for them, particularly with stage 1 disease. If we take stage 1 disease, they have a very, very high survival pattern, and it's probably worthwhile just waiting and not commencing it until we get through the surgical phase, if you understand me. We don't want to get DVTs and blame it on HRT. So we would wait a few months. Having said that, if the situation is of concern, there are many people, and I've done it myself in the past, who say, listen, do you want to wait for a year or thereabouts? Because we know most of the relapses will happen within the first 1 or 2 years, and then we can start it. That's an option that you can give the patient. But the reality is, I suspect most of them are coming because of symptoms, and I would probably wait a few months, 3 to 6 months following their surgery, so that we don't have HRT being blamed on causing DVTs or such like. That's where matters get very confused, and in the UK, the general practitioners really get concerned about prescribing HRT. Having said that, in the UK, most of them will probably not handle that in patients who have got cancer. We would handle that ourselves if necessary. So, you know, I think you can give it earlier if you so wish. I don't think you have to wait the 2 years, but if you are concerned about giving the HRT and I'm concerned about the relapse, you could say to the patient, nearly all the relapses are going to happen within the first 2 years. Would you feel comfortable waiting 2 years? And you can have it then. But I would have anticipate that many of the patients coming looking for HRT just need the information, probably themselves will start it anyway due to their symptoms.
Okay, thank you. Next question is from Rika Wontakal again. Is there any risk of recurrence when HRT is given to women with borderline cirrhosis or mucinous rumors of ovary? Additional note, these women are usually young, symptomatic, and need HRT.
Yeah, it's a good question, that, because the borderlines is slightly different in the sense that there is some evidence that the HRT itself might be problematic. Having said that, in the vast majority of borderline patients, yes, I agree with you, they are young, but they're generally speaking stage 1 disease, so we tend to leave some ovarian tissue behind. So it's very unusual that we remove everything out of these patients. That's usually in advanced disease, whereby we have to remove all of the ovarian tissue. In that case, I think it's a very straightforward scenario whereby, whilst we don't have the evidence, again, their quality of life is paramount. And if we have no alternatives, I would give them HRT, explaining to them there might be a slight increased risk in those cases of the disease recurring. but that the evidence is sparse on that, and therefore their quality of life is paramount. But clinically, most of the borderline tumours that we receive in younger patients are those with stage 1 disease, and therefore we don't actually have to give them HRT. Your second question, what was the second part of that question, please?
Oh, I was additional note. These women are usually young, symptomatic, and need HRT.
But there was borderline, and there was something else you asked about, I thought.
Oh, no.
It was just,
yeah.
So
okay, so yeah.
So what I'm saying is I would treat those patients if they're symptomatic and young. I think their quality of life is very, very important as well. And we have to remember that, you know, in borderline tumors, most patients won't die. You did mention about mucinous tumors. And I think you were probably talking about the borderline mucinous type tumors, which is fair enough. I will just batch all the borderlines together. I wouldn't worry about being mucinous or serous.
All right, thanks. Last question is from Manju Navani again. Can HRT be given to all ovarian cancers except granulosa cell tumors in any stage after surgery?
Yeah, it would look from the evidence that it's reasonable to give this, but the types of patients I think are patients with no residual disease. And from what I can see in the literature, these seem to be patients who are going to do extremely well. As you can see, the follow-up in many of the studies is 3 or 4 years, and quite often a lot of our stage 3 disease wouldn't be alive at that. So these are probably a select group of patients. I would be definitely cautious. I definitely wouldn't give it to the patient with granulosa cell tumors. In many cases, you don't have to give it anyway. There will be the rare ones. I can't go through each individual rare type tumor in younger patients and the germ cell tumors. The reality of those types of rare tumors is the fact that they usually are stage 1. We take the tumor out, we often treat the patient with chemotherapy, and then their ovarian function comes back 12 months later. And in those young people, they have children, they have families, pretty much the same as everybody else, without any detrimental effects noticed on the babies that are born of those women. So HRT doesn't become an issue. But if you are coming across extremely rare ones, that's very important that if HRT is being considered, that you have very good pathology and some information onto the estrogen receptor status of the rare tumors, just in case you are running into a scenario, for example, like stromal cell carcinomas, whereby it may be wise to avoid HRT. But all of those need to be taken on an individual basis, discussed with the pathologists and also the gynaecological oncologists as well.
Okay, Manju just added a note that endometrioid cancers cannot have HRT too.
The endometrioid, well, you could debate that. They're going to be in there somewhere. I think, you know, as I say, from all of the studies we have, all we can say is that in the patients who were randomized in these studies that you noted were serous and mucinous tumors, you didn't see any endometrioid there. And the reason you don't see them, as he quite properly points out, is concerns about the fact that you may, because of their estrogen-driven component, that you may well cause it to return earlier. But we don't have any evidence to say yay or nay to that. Clinical practice will probably dictate, he's quite right, that, you know, let's avoid it in these scenarios.
Okay. Can we have more time because there is one extra question?
Yep, absolutely, yes. Yeah, I'm the person who's late. I'm here, don't worry.
Okay, another question from Rika Wuntakal again. Borderline rumors. Is the risk of recurrence in these women high with ovulation, induction, or IVF? Can HRT be offered to women with any grade of endometrial cancer, like grade 2 or 3 or stage 1?
Yeah. So if I take the borderline tumors, I think Kurt Berger in the Netherlands did really very, very good work on this. I think it was for fertility treatment, because a lot of the work that's been done epidemiologically on fertility treatment, you find that there's a lack of exactly what the patient took for their fertility treatment, exactly how long they took it, etc., etc. And Kurt in the Netherlands did work where he prospectively followed up women who had various treatments for their infertility. What he found was that in those patients, if they did have fertility treatment, he was the first to show that they didn't have an increased risk of invasive ovarian cancer, but they did have an increased risk of borderline tumors. So we can say to patients that if you are having fertility, you will get an increased risk of borderline tumors based on the prospective study. That's the first thing. Nevertheless, these borderline tumors are curable. So they're highly curable disease. Relapse rates are deemed somewhere in the region of 10 to 15%, usually 10 or 15 years later. So you may relapse, have your operation, and you're back to where you were at the very, very beginning. That's all we can say. The caveat always in these things is that they're not randomized patients. And to that extent, we always have to leave a little bit of a gap there. We won't be able to do randomized trials on treating patients for fertility or not treating them and see what happens in the same situation. There's always going to be that gap in our knowledge. But you can say, yes, there's an increased risk. It's not an immense increased risk that would stop people having children or going for fertility, but it does exist. But probably what's more important is the fact that the concept of invasive disease being associated with fertility, I think that study shows actually that is not the case, and that's very reassuring in that situation. The other part of the question, the second part was? Hello?
Can HRT be offered to women with any grade? Hello? Can you hear me?
Yes, I can indeed. Yeah.
Hello.
From the information we've available from the meta-analysis of women with endometrial carcinoma, and remember, most of these are stage 1, stage 2, but from the meta-analysis, it didn't seem to make any difference whether they were grade 1, 2, or 3 tumors. You could give them HRT, and the overall impact seemed to be no impact at all. So the grade of the tumor didn't seem to matter too much, interestingly.
Okay. Okay. I think that is all.
Fantastic.
Thank you so much.
Well,
Do you have anything else to share?
No,
Yes,
that's
Professor?
it. No, that's it, really. That's the lot. And again, my apologies about I couldn't avoid a car crash happening in front of me, but there we go. It's one of those things. So thank you very much for all your patience.
Okay. Do you have anything else to share before we wrap up?
No, I don't indeed. No, I'm done. Thank you.
Okay. Thank you. Okay, thank you so much for the presentation, Professor Kehoe, and thank you for all the attendees for sticking with us today, despite the delay.